Imagine going into the hospital to fix what most people consider just a routine quality of life issue, like a leaky bladder.
Right, something that's super common.
Exactly. But because you have this chronic smoker's cough or maybe COPD, that routine elective surgery suddenly increases your risk of dying in the next year by like 61%.
Which is just a staggering number to wrap your head around.
It really is. So you are suddenly caught between living with this, deteriorating quality of life or literally risking your actual life to try and fix it. Welcome to today's Deep Dives, where we are tackling this exact mission for you.
Yeah, it is the ultimate medical catch-22.
It really is.
Yeah.
We are looking at your stack of clinical guidelines, medical studies, expert articles to explore a very specific, highly complex patient scenario. We're talking about someone dealing with stress urinary incontinence, but who also has a severe chronic cough.
And we really need to emphasize that we're navigating some heavily conflicting data here.
Oh, absolutely. So should this patient choose traditional surgery, or should they pivot to these minimally invasive energy-based devices like transvaginal lasers or radiofrequency?
Right. And looking at your sources, which include the NICE guidelines, the AUSUFU surgical updates, and these new comparative studies, we are going to objectively navigate this. There are FDA warnings, surgical risks, and we aren't taking any sides. We just want to give you the ultimate roadmap to understand all of this.
So to even begin figuring out how to fix the problem, we first have to understand the mechanics of why a chronic cough actually causes leakage.
Yeah, we have to look under the hood. So we're talking about stress urinary incontinence, or SUI, and the clinical data you provided shows SUI accounts for nearly half of all urinary incontinence cases in women.
Half. Wow. Oh.
Yeah, it's incredibly prevalent. And we should clarify, stress here has absolutely nothing to do with like anxiety or emotional overload.
Right, it's not mental stress.
Exactly. We are talking strictly about physical mechanical stress that's being placed on the bladder.
Okay, I was trying to visualize this when reading the sources, and the easiest analogy is basically an untied water balloon.
I love that analogy. It works perfectly.
Right, so the bladder is the balloon holding the water, and the urethra, the tube where urine actually exits the body, is the floppy neck of that balloon.
Yep, that's the anatomical setup.
So if you squeeze the balloon itself, water is naturally just going to spill out unless you are actively pinching the neck closed at the exact same time.
That's exactly what happens in the body. When you cough, laugh, sneeze, or lift something heavy, your diaphragm pushes down like a piston.
So you're squeezing the balloon.
Right. Your abdominal muscles contract violently, creating this sudden, massive spike in your intra-abdominal pressure. You are essentially stomping on the water balloon.
But I mean, I can sneeze or laugh without leaking. Most people can. So what is naturally pinching the neck of the balloon?
That would be your pelvic floor. In a healthy system, your pelvic floor muscles and the connective tissue around them provide instant counter pressure.
Like a reflex.
Exactly, an automatic reflex. The moment that intra-abdominal pressure spikes, the pelvic floor acts like a firm backstop. It squeezes the urethra shut against the vaginal wall, keeping the urine safely inside the bladder.
Okay, let's unpack this. Introduce a chronic cough into that system, say from COPD or a long history of smoking.
Well, then the math completely changes because a chronic cough is relentless. It's not just a sneeze once a day. It's a repetitive, violent shockwave hitting that pelvic floor dozens, maybe hundreds of times a day.
For years on end.
Yes, for years. So over time, those pelvic floor muscles just become totally exhausted. The connective tissue literally stretches out and loses its elasticity.
It's like a rubber band that's been pulled too many times. It just hangs there loose.
Precisely. So the pelvic floor drops. It fails to provide that firm backstop. When the next cough hits, the urethra isn't squeezed shut against anything solid anymore. It just gets pushed downward, the seal breaks, and the patient leaks.
So if the physical structure, the pelvic floor itself, is stretched out and failing under the constant pressure of this cough, doesn't that mean we need a physical structural repair to fix it? Like, you don't fix a collapsing bridge with a pill?
You bring in steel cables.
Exactly.
And honestly, that logic has driven urogynecology for decades. If the structure has failed, you physically rebuild it. Which brings us to the surgical options, traditionally considered the gold standard for SUI.
Right. The sources highlight two main ones: midurethral slings, the MUS, and the Birch-Colpo suspension.
Yeah.
I know what a sling is, but the Birch procedure sounds pretty intense. What exactly is a Colpo suspension?
Well, colpo refers to the vagina, and suspension means to lift. So in a Birch procedure, the surgeon actually goes into the lower abdomen, places permanent stitches in the vaginal wall right beside the urethra, and ties them to a strong ligament behind the pubic bone.
Oh, wow. So literally pulling it up.
Right. It physically pulls the tissue up to recreate that solid backstop we talked about.
And the midurethral sling operates on a similar idea, right? The sources used a Golden Gate Bridge analogy.
Yes, it's a very similar architectural principle.
The surgery acts like the vertical cables of a suspension bridge. The surgeon loops a piece of synthetic mesh under the urethra to hold it up. So when the downward force of a cough hits, the urethra is structurally supported and gets squeezed shut against that mesh hammock.
Mechanically, both are very sound procedures, and the data from the Barasat Medical College study backs this up.
Oh yeah, those success rates were high.
Very high. They tracked women over a year, and the midurethral sling boasted an 85% continence rate. The Birch procedure hit 78%. In the surgical world, those are incredibly impressive numbers for a structural fix.
But wait, our listener is asking about a patient with a chronic cough.
Mm.
And usually a severe chronic cough means a condition like COPD. If they have COPD, isn't major surgery really risky?
That is the pivotal question. If we connect this to the bigger picture, it's a profound systemic risk. The Canadian Medical Association Journal study, in your sources, looked at over 900,000 patients undergoing major elective surgeries.
That's a massive sample size.
Huge. And they found that patients with COPD who undergo major surgery are 61% more likely to die in the year following the procedure compared to similar patients without COPD.
61%. Just from going in to fix a leaky bladder. How does that even happen?
Well, it's the reality of general anesthesia on already compromised lungs. When you go under, the anesthesia essentially paralyzes your respiratory muscles. A ventilator breathes for you.
Okay.
For healthy lungs, waking up and coming off the ventilator is totally routine. But for a frail patient whose lungs are damaged by COPD, restarting that natural respiratory drive is incredibly difficult.
Yeah.
They're highly prone to pneumonia, collapsed lung sacs, prolonged ICU stays.
So for a frail patient, this gold standard surgical fix might literally just be too dangerous for their overall health.
Exactly. And that's not even mentioning the immense public concern and FDA warnings regarding the synthetic mesh used in those slings.
Right, the mesh controversy. I see commercials about that all the time.
It's a huge issue. The mesh provides strong, permanent support, but it's a foreign plastic body. It carries risks of erosion. It can actually rub through the delicate vaginal wall or into the urethra.
That sounds agonizing.
It causes chronic pelvic pain, recurrent infections, and removing it is incredibly complex because the body's tissue grows through the microscopic pores of the plastic.
So we are totally stuck. A frail patient with a cough that's destroying her pelvic floor, but general anesthesia might kill her, and the mesh might leave her in chronic pain.
Yeah.
So we skip the operating room entirely, right?
This is exactly why the field is looking at minimally invasive alternatives, energy-based devices or EBDs.
The transvaginal lasers and radiofrequency devices.
Right. Erbium or CO2 lasers and radiofrequency systems like the Vivev or Renessa. Instead of a surgical hammock, these use heat to trigger a biological process called neocollagenesis.
Okay, neo means new, and collagenesis means making collagen. But how does applying heat actually rebuild a stretched-out pelvic floor?
It relies on a controlled thermal injury. The devices are inserted transvaginally and they heat the vaginal wall or urethral submucosa. For RF, the temperatures are usually 40 to 45 degrees Celsius.
Just kind of warming it up.
Right, but they can push it up to 65 to 75 degrees for what's called focal microscopic denaturation.
Okay, denaturation is a heavy medical term. What does that actually mean for the tissue?
Think of cooking an egg white. When raw, the proteins are folded in a clear, liquid way. Add heat, and the weak chemical bonds break. The proteins uncoil, tangle up, and turn solid white.
Oh, interesting.
That's denaturation, changing the microscopic structure of the protein with heat.
So the laser, or RF wand, is literally cooking the old, stretched-out collagen in the pelvic floor.
Yes, and that specific thermal damage acts like an alarm bell for the immune system. It stimulates fibroblasts, basically the body's cellular construction workers, to rush in. Over the next 90 days, they lay down dense, fresh, tightly woven collagen and elastin.
Wow.
And as that new tissue matures, it shrinks and tightens the whole area, resisting the pressure of the cough.
Here's where it gets really interesting. Your sources included an MDPI comparative study between laser and radiofrequency. And the difference in the patient experience is just wild.
It really is. Both showed clear benefits. They both improved vaginal health and sexual function scores, the FSFI scores, but RF proved far more tolerable.
Yeah, the numbers are crazy. Nearly 96% of radiofrequency patients reported good improvement scores, compared to just 74% for the laser. And the pain metric.
Yeah, the pain difference is massive.
The procedural pain score for RF was mere 14.1. The laser scored a 53.6. Why does the laser hurt so much more if they're both just, heating up the tissue?
It comes down to how the energy interacts with the body. Lasers use light energy that's highly absorbed by water. When it hits the surface of the vaginal tissue, it literally vaporizes the water in those surface cells.
Vaporizes, so it's burning the top layer.
Exactly. It's an ablative process. It destroys the surface to force healing from the top down. That leaves microscopic raw channels on the tissue surface, which is highly sensitive.
And radiofrequency doesn't do that.
No, RF uses an alternating electrical current. It passes harmlessly through the surface layer and meets electrical resistance deeper down, so you get the deep tissue heat without the surface burns.
Hence the super low pain score.
Right. Plus, these are outpatient procedures requiring zero downtime, which makes them incredibly attractive for someone whose frail lungs cannot handle general anesthesia.
This sounds like the absolute perfect solution. It's painless, no anesthesia, tightens the tissue to stop leaks. Why isn't every doctor just doing this instead of the risky mesh surgery?
Well, this is where we need a reality check. We have to look at what the official medical guidelines actually say, and they heavily disagree with that optimism.
Let me guess. They look at the 96% improvement with RF and say it's not good enough.
The guidelines from NICE in the UK and the AUSUF here in the US, they are the gatekeepers. And despite promising short-term data, like the ICIQ scores dropping in trials, they do not recommend RF or laser as a standard treatment for SUI.
Seriously?
The AUA specifically excludes transvaginal RF from their approved treatments, and NICE states the evidence is inadequate in quality and quantity for long-term efficacy. They consider it experimental.
But the studies show it works. Why are the guidelines so incredibly strict about this?
Because a chronic cough is a mechanical, lifelong force. Heating the tissue gives you a temporary collagen boost. But there is no robust 5 to 10-year data showing that this heat-induced collagen can continually withstand the violent, repetitive abdominal pressure of a chronic cough.
I see, so it wears off.
Yeah, often these patients require top-up sessions every 6 to 12 months. It's a biological patch, not permanent steel cabling.
And doing multiple rounds of tissue burning procedures probably carries its own cumulative risks, right?
It does. The FDA has actually issued safety communications warning against using energy-based devices for what's marketed as vaginal rejuvenation. They've seen reports of severe burns, scarring, and chronic pain during sex.
Ouch.
This raises an important question. Are we trading a known surgical risk for an unknown long-term technological limitation?
So synthesizing all of this for the listener, for a woman with a chronic cough, this is really a battle between mechanical strength and systemic risk. You have to weigh the danger of the cough against the danger of the cure.
It is the epitome of shared, individualized decision-making. If the patient's cough is caused by severe COPD, the extreme risks of major surgery, that 61% higher mortality risk, might make the experimental but non-invasive laser RF options a much smarter, safer choice, even if they require annual maintenance.
Because getting a touch-up every year is better than not waking up from anesthesia.
Precisely. But conversely, if the patient is otherwise healthy, they just have a chronic mechanical cough, but their lungs are physically strong. A mid-urethral sling provides the proven, durable structural support required.
Assuming she is fully informed of the mesh risks through a patient decision aid, like the NICE-E guidelines strongly recommend.
Exactly. Informed consent is paramount here.
Now, there's briefly a third way mentioned in the sources, a totally non-surgical, non-device alternative, a medication called duloxetine, or Cymbalta.
Duloxetine is fascinating. It's an SNRI originally developed as an antidepressant, but researchers found that altering those neurotransmitters actually stimulates the pudendal nerve, which increases the resting muscle tone of the urethral sphincter.
So you take an antidepressant pill to physically flex a pelvic muscle.
Yeah. And it improves SUI symptoms about 60% of the time. But the massive caveat is that it requires indefinite use. You stop the pill, the leaking returns. Plus, you have to manage the side effects of taking a daily SNRI.
Which just highlights why shared decision-making is so crucial. There is no magic bullet here at all.
Yeah, there really isn't. You have to look at the whole patient.
Well, this has been an incredibly complex deep dive. Thank you for bringing such a nuanced, layered medical topic to the table for us. To summarize your sources, the choice between surgery and energy devices isn't just about the bladder. It requires looking at the lungs, the cough, and the patient's tolerance for risk.
Before we wrap up, I want to leave you with a final concept to mull over. Right now, surgery is the gold standard because we rely on synthetic mesh to mechanically hold our anatomy in
It's
place.
steel cables.
But as radiofrequency and laser technologies evolve to better stimulate our cellular biology, will there come a day when the medical field completely abandons structural implants?
Oh, wow.
Will we eventually view putting plastic mesh inside the human body as outdated, relying entirely on the body's own regenerated collagen to fight the mechanical stress of gravity and coughing?
That is a wild thought to leave on. Maybe the future of medicine is just giving the body the exact tools it needs to constantly rebuild itself. Thank you for joining us on this deep dive into your research. Keep asking those complex questions, and we'll catch you next time.